So today we, as you know, that we are all rushing with nerve muscle physiology. Today's topic is very essential topic, right? मतलब case based learning हम लोग आज सीखेंगे. What is actually meant by case based learning through our neuromuscular junction. And the important objectives of this is that you should be able to draw a well labeled diagram of neuromuscular junction. You should be able to elaborate the sequences, okay, or the events that take place at NMJ. What is end plate potential, what is the physiological basis, and what is the feature of myasthenia gravis, right? अब देखो, मतलब let us start with very interesting historical stories. Now you can see what is this, and can you correlate it? Yes, you know that how was Krishna ji's death? It was because of hunting, and the arrow was struck over his foot. So this is the historical myth which was related. Now we don't know how much it was correct, but it was supposed to be a poison, that is a curare poison, which was affecting the neuromuscular junction. Second very interesting thing is that this is, you know, the hunting which is done, right? If you know about hunting, the South Americans, what do? They put something over here on their arrow so that the animal is paralyzed when they're hunting. So these two are the important things where we have to remember that there is something which is related to neuromuscular junction, right? And at the end of the day, you will also be able to correlate the how the toxicity develops with snake bite, what is the physiological basis of treatment of myasthenia gravis, what is OP poisoning. तो ये सारी चीजें प्लस ये टॉपिक इज वेरी important when in the second MBBS you're going to study your pharmac, because there are list of drugs which act on neuromuscular junction. So by and large this is very interesting topic. एग्जाम पॉइंट ऑफ व्यू हाई यील्डिंग टॉपिक है ये, ठीक है? तो अब इसको समझने की कोशिश करते हैं हम लोग. सपोज मैंने आपको एक एक आपको मैंने फ्लैश कार्ड दे दिया, राइट? और इस फ्लैश कार्ड पर से आई एम टेलिंग यू हाउ डज न्यूरोमस्कुलर रिसेप्टर फाउंड at the skeletal muscles neuromuscular receptor differs from that of the neuromuscular junction which is present in the bronchioles. तो एकदम से what should be, you know, into your mind is कि what is the neurotransmitter? Is it same at the skeletal muscle as well as at the smooth muscle? Why it is smooth muscle? Because bronchioles मैंने बोला तो it will be what? It will be our smooth muscles. तो दोनों same है क्या? Then what causes weakness in myasthenia gravis? This you should be able to elaborate. And all these steps 1 2 3 4 5 6 and all these steps you must be able to elaborate your answer, because this is very important LAQ, that is the sequence of events which take place at NMJ. मतलब most favorite question of neuromuscular physiology is there. ठीक है? So let's get started. First, very important, we should know before we come into, you know, we'll just start with the case history. Now this is the case of a 32-year-old woman who is coming to a physician with difficulty in chewing, and she complains that especially there is difficulty when she's chewing meat. Jaw becomes tired, becomes weak, and after a period of rest the jaw muscles again regain their strength and she starts eating better, right? तो एक ये history हो सकती है. Then another history which can be given to you is that a woman is coming, or any person is coming with history of, you know, weakness, especially feels tiredness towards the end of the day, okay? And after rest the symptom improves. तो जब भी ऐसा होगा कि after rest the symptoms improve, there is muscle weakness, okay, there is blurring of vision, all these symptoms they are correlating to something which is called as myasthenia gravis, okay? So the diagnosis of this is myasthenia gravis. Now the another favorite question which is asked over here is that what is the physiological basis for treatment of myasthenia gravis, right? What is the physiological basis of treatment of myasthenia gravis? And if we give an acetylcholine esterase inhibitor, ठीक है, what would be the effect at NMJ? ये सब questions इस पर्टिकुलर टॉपिक से रिलेटेड है जो हमको आना चाहिए. बट सबसे पहले what we will do is we will try to understand the structure of neuromuscular junction. Now I tell you how to remember. See, this is a very beautiful sequence that is brought about by the brain to the skeletal muscle. Now suppose I have to drink water or I have to write something, कुछ भी हो सकता है, which is totally a voluntary activity. So let's start from here. There is first going to be a thought process in the cortex that I want to drink. This is going to be transmitted through your long pyramidal tracts, that is the corticospinal tracts. And you know that the corticospinal tracts, they end on the alpha motor neurons. Where is these alpha motor neurons? If you look into the spinal cord, ठीक है, अगर आप आपका स्पाइनल कॉर्ड देखोगे जो आपने 12th में भी पढ़ा हुआ है, this is the dorsal horn of the spinal cord and this is the ventral horn of the spinal cord, and here are your alpha motor neurons. So this tract is going to end on this alpha motor neurons, right? Once the tract ends on this alpha motor neuron, from this its nerve fiber is going to supply your skeletal muscle. Okay, it is going to supply your skeletal muscle. So this nerve fiber, you remember, this nerve fiber will end in the form of these terminals, and each of these terminals have got synaptic knobs which store the neurotransmitter substance. So this is going to form a neuromuscular junction. That means the nerve fiber which is going to terminate on the part of the skeletal muscle is what is your neuromuscular junction. So remember, it is not present with the smooth muscles or with the cardiac muscles. Neuromuscular junction is present only with your skeletal muscles, because the skeletal muscles are your voluntary muscles, right? They are your voluntary muscles. If there is any doubt to those who are live, तो please मतलब बताते जाना अगर आपको लगता है कि कुछ doubt है, so you can please let me know. Okay. Now, so this alpha motor neuron will lose its myelin sheath and the nerve terminals will form a junction. So you can see over here that the axon losing its myelin sheath, it will form a junction with the part of the muscle. So once there is also a concept of motor unit, we will see what is a motor unit, and we will see that how many muscle fibers will be innervated by one alpha motor neuron. So remember that the outside, okay, this large myelinated nerve fiber will end in the middle of this muscle fiber. The part of the muscle fiber which is taking part or which is getting incorporated as the neuromuscular junction is called as the motor end plate. ठीक है, तो जो मसल का पार्ट होता है जो न्यूरोमस्कुलर जंक्शन बनाएगा उसको हम लोग बोलेंगे मसल एंड प्लेट. ठीक है. नाउ लेट अस स्टडी द स्ट्रक्चर ऑफ दिस मसल neuromuscular junction. Neuromuscular junction is an example or it is a type of a chemical synapse. ठीक है, it is a type of a chemical synapse. There are two types of synapse which we will study in CNS, electrical synapse and chemical. तो ये आता है, it is a kind of chemical synapse. So जो ये न्यूरॉन वाला पार्ट है, this is going to be the presynaptic portion. Okay, presynaptic. और जो ये मसल वाला पार्ट है, this muscle वाला part is actually called as the invaginated membrane. This invaginated membrane is called as synaptic trough or the synaptic gutter. Right? The invaginated membrane is called as the synaptic trough or the synaptic gutter, and you can see that it is thrown into folds. Right? See, it is thrown into folds. These folds are called as subneural cleft. Basically what these folds do, they basically increase the surface area. Everywhere where there is node, everywhere जहाँ पे भी there are going to be folds, you know, उनका एक ही काम होता है that they are going to increase the surface area, right? So यहाँ पर remember it is thrown into folds and these are called as the subneural cleft, muscle वाला portion. और बीच में जो ये स्पेस दिख रही है, तो ये मसल वाला जो पोर्शन है जिसको हमने मसल एंड प्लेट बोला है, दैट इज द पोस्ट सिनेप्टिक एरिया। ओके, पोस्ट सिनेप्टिक। तो एक्सॉन वाला पार्ट होता है प्री सिनेप्टिक और मसल वाला पार्ट होता है पोस्ट सिनेप्टिक। जो बीच में छोटा सा स्पेस है, दिस स्पेस, दिस इज योर सिनेप्टिक क्लेफ्ट और द सिनेप्टिक स्पेस। It is called as the synaptic cleft or the synaptic space, which is around 20 to 30 nanometer wide. Okay, 20 to 30 nanometer wide. In this synaptic space or the synaptic cleft, you will have calcium ions because there is extracellular fluid, and you will have the enzyme acetylcholine esterase. ठीक है, दो चीजें मिलेगी, एक तो कैल्शियम आयंस मिलेंगे, दूसरा एसिटाइलकोलिन ईस्टरेज मिलेगा। अगर आप एक्सॉन वाला साइड देखेंगे, इन द एक्सॉन वाला साइड देयर आर गोइंग टू बी rich number of mitochondria. They are very important because the mitochondria will be the source of energy, right? You have to bring about exocytosis. There are synaptic vesicles. These synaptic vesicles will contain neurotransmitter, that is acetylcholine. Okay, it will contain the neurotransmitter, that is acetylcholine. Now moving next would be, see, you can see another important thing in this neuromuscular junction on the presynaptic membrane. Presynaptic membrane matlab axon wala side, there is linear arrangement of what we called as dense bar. Okay, linear arrangement of what we called as the dense bar, and on either side of the dense bar you have got calcium channels. So remember very nicely that these are voltage gated calcium ion channels. Okay, they are voltage gated calcium channels, and where they are present on the side of the axon, matlab on the presynaptic portion of the synapse. ये इसीलिए important है because there are important diseases and conditions which are related to presynaptic and postsynaptic membrane. इसलिए हमको याद रखना है कि on the presynaptic side there are voltage gated calcium channels. Okay, and there are dense bars, and जहां से there is going to be the release of the neurotransmitter substance, उसको हम लोग बोलते हैं active zone, right? We called it as active zone. Now if you look into the post synaptic membrane, मतलब towards the muscle वाला side, जहां पर हमारे ऐसे folds थे, subneural cleft थे, उसके mouth पर अगर आप देखोगे there will be acetylcholine receptors. Acetylcholine receptors are examples of ligand gated channels. Ligand matlab something is going to attach. Who is going to attach? Acetylcholine, and it is present almost at the mouth of the subneural cleft, right? And binding of two acetylcholine molecules is required to open that, right? Two acetylcholine molecules are required to open that. Which type of receptors are these? Acetylcholine के दो receptors होते हैं, nicotinic and muscarinic. तो जो muscarinic receptors होते हैं, muscarinic, they are mainly present on the target areas, like heart में जहाँ पर acetylcholine will be acting upon, receptors would be muscarinic. Bronchial muscles में muscarinic. But nicotinic receptors of the acetylcholine, they are present in the ganglias. Okay, they are present in the ganglias, and they are also present in the NMJ, that is your neuromuscular junction. Okay, so again we'll have a quick revision before we move forward. So we are having a presynaptic portion that is formed by the axon. Very important thing is the mitochondria and synaptic vesicles to be remembered. Also to be remembered are active zones. एक्टिव जोन्स वो वाला साइड होता है जहां से आपका न्यूरोट्रांसमीटर रिलीज होने वाला है, ठीक है? तो वहां पर देयर आर डेंस बार. ओके, डेंस बार के ऑन ईदर साइड देयर आर वोल्टेज गेटेड कैल्शियम चैनल्स, राइट? ऑन द पोस्ट सिनेप्टिक साइड, सबन्यूरल क्लेफ्ट के माउथ पर देयर आर ligand gated channels which are acetylcholine gated channels, जो खुलेंगे जब दो acetylcholine molecule उस पर अटैच होंगे, राइट? एंड जो हमारा सिनेप्टिक स्पेस है या सिनेप्टिक क्लेफ्ट है, वहां पर ECF होता है, तो हमको वहां पर मिलेंगे कैल्शियम आयंस, एंड वी विल बी गेटिंग एसिटाइलकोलिन एस्टरेज वाला एंजाइम, राइट? सो दिस इज अ वेल लेबल्ड डायग्राम ऑफ योर of this, that is your neuromuscular junction. Now you should come in, what should come into your mind is ki what is the role of calcium over here? राइट. व्हाट इज द रोल ऑफ कैल्शियम? तो जब हम लोग पूरा सीक्वेंस पढ़ेंगे तब आपको समझ में आएगा. बट लेट मी टेल यू दैट दिस कैल्शियम, okay, when it will enter inside, will activate the calcium calmodulin protein kinases. Calcium calmodulin protein kinases. Okay, so what they will do, they will bring about phosphorylation of certain proteins which are called as synapsin, that are bounded to the vesicles, right, that are bounded to the vesicles. That is going to cause the phosphorylation of proteins called as synapsin which are present on the vesicles. So basically this is going to help in the docking and the release of neurotransmitter substance. ठीक है, it is going to cause the docking and the release of the neurotransmitter substance into that synaptic space. ठीक है. Now, apart from this, obviously energy will be required in the form of ATP. You require certain docking proteins. So even if you remember the docking proteins, it is sufficient. They are called as SNAP, which is synaptobrevin. Okay, which is synaptobrevin, syntaxin, synaptobrevin, syntaxin. These proteins are present on the vesicles. V-snare protein बोलते हैं उसको. And they are also present on the presynaptic membrane. So vesicles में proteins है और presynaptic membrane में proteins है, right? ये देखो, एक तो प्रोटीन रहेंगे vesicles में और दूसरे प्रोटीन्स रहेंगे हमारे मेम्ब्रेन में. सो दीज आर गोइंग टू अटैच, ओके, द प्रीसिनेप्टिक मेम्ब्रेन वाले जो प्रोटीन्स है, दे आर गोइंग टू अटैच to the proteins which are present on the vesicles, and this ultimately will result in what? This ultimately will help in the fusion and the release of the neurotransmitter substance, right? So you have got docking proteins like synaptobrevin, syntaxin, which play an important role in the docking and the exocytosis of the neurotransmitter substance. So correct protein on the vesicle will bind to correct protein on the membrane, and ultimately you will release the content. This is very important because there can be certain toxins, there can be certain poisons, there can be certain drugs which can act on this mechanism and prevent the release of acetylcholine, which we will see in the applied part. ठीक है, इसीलिए डॉकिंग प्रोटीन्स को याद रखना, क्योंकि ऐसे कुछ ड्रग्स हो सकते हैं, कुछ पॉइजन्स हो सकते हैं which can act on that portion and they can interfere with the release of acetylcholine. Okay, so this is how there is the the structure, and this is the role of the molecule, that is the calcium, which is important over here. Now, as far as your, if you look into the formation of acetylcholine, that where is acetylcholine formed, तो थोड़ा सा आपको पता होना चाहिए कि where is acetylcholine formed. The acetylcholine is actually formed in the Golgi apparatus of the cell body of the neuron. It is formed in the cytosol, especially it is formed in the Golgi apparatus of the cell neuron. ठीक है, गोल्गी बॉडी के जो आपका जो न्यूरॉन है, जो उसका सेल बॉडी है, मतलब सोमा, वहां पर आपको दिखेगा कि acetylcholine is being formed. Okay, and you can see that these vesicles, they are about 40 nanometers in size. The vesicles are about 40 nanometers in size, and they are transported all the way from the body of the axon towards the terminal. And if you remember, these were called, this was called as the antegrade axonal transport. It was called as the antegrade axonal transport, and about 3 lakhs of these vesicles are present at the nerve. 3 lakhs of these are present at the skeletal muscle end. इतने सारे होते हैं, there are about 3 lakhs in number of these vesicles are present at each muscle end plate. So you've got enormous amount of safety factor, which we called. Okay, now this acetylcholine is transported in the vesicles, and each vesicle can contain about 10,000 acetylcholine molecules, and you will be surprised that the action potential, जो जब हमारा एक maximum और जब एक action potential develop हो जाता है, one action potential can release about 125 vesicles. So 125 into 10,000, this much amount of action potential, this much amount of neurotransmitter can be released. So each vesicle contains about 10,000 acetylcholine molecules, and when we set up a full-blown action potential, about 125 vesicles can be released. This itself is called as the safety factor, which we will elaborate, right? Now, and after the work is done, okay, once the acetylcholine has brought about its work, you remember that acetylcholine will be again hydrolyzed by the enzyme acetylcholine esterase. It will be converted into acetate and choline. Now, this is very important to know that choline is not so readily available. It has to be taken by from the diet. So the neurons have to preserve it very well, and therefore when it is hydrolyzed, this choline will be taken up by the nerve terminals, and it will be used for recycling, right? It will be used for recycling. So it is very important that the choline must be taken up and again go back for recycling to be utilized in a proper manner, because the neurons, they cannot synthesize choline as such. Okay, now what we see is, we obviously we'll have the entire events which will take place. So remember, events में होता क्या है, जब आपका when there is going to be a thought process and the action potential is going to travel all the way via the corticospinal tract, end up into the alpha motor neurons and the nerve of the alpha motor neurons, which is going to terminate on the skeletal muscle fiber, and then result in the sequence of events which take place at NMJ, right? So up till now, I hope it is very, very clear that what is the role of calcium ions and everything. Now, this acetylcholine, what does it do? This acetylcholine, here is the figure also, I'll show you, and then we'll elaborate the entire steps. हम लोग फिर पूरे steps एक साथ पढ़ लेंगे. So you can see that this is the acetylcholine channel, that is your nicotinic ligand gated channel. This is the closed part, and when two acetylcholine molecules, they bind on the receptor, there is opening of the channel. Now the diameter of this channel, is around 0.65 nanometer. And it is quite permeable to positive ions. That means it is permeable to be calcium, for sodium and potassium. But remember, the main cause of development of the muscle end plate potential and then the action potential is your sodium. So don't get confused. If you are getting an answer, it is mainly your sodium ions which are responsible. There can be influx of calcium, very small amount, and a very small amount of efflux of potassium, right? Because they move down their concentration gradient. But the main cause of setting up of an action potential is the presence of the sodium influx, right? Now, that means more sodium is going to enter inside as compared to the other ions. Now, once the work is done, okay, now we are going to elaborate the entire process in the form of a flow chart, but understand figure wise. Once the acetylcholine is released into the synaptic space and it brings about its action, there are two ways. First is small amount of it also go into diffusion into synaptic space. Okay? Diffusion into synaptic space, small amount, and a major amount of it is going to be destroyed by the enzyme acetylcholine esterase, right? The major amount of it is going to be destroyed by the enzyme acetylcholine esterase. ये एंजाइम एसिटिलकोलिन ईस्टरेज याद रखना आपको बहुत ज्यादा इंपॉर्टेंट है, बिकॉज you get physiological basis of treatment of myasthenia gravis, and next year when you will be studying pharmacology, you will be having a variety of drugs which are acting at this particular site. So anticholinergic or anti acetylcholine esterase, that time you will have to recollect this physiology wala part. Now what is a muscle end plate potential? What do you mean by a muscle end plate potential? So remember, I'm going to elaborate the entire thing in the form of a flow chart, but uske pehle we will just study step by step, because these are the things which are separately asked as question. So what is the muscle end plate potential? Right now, once the sodium influx is there, right, once there is sodium influx, you know that the resting membrane potential is minus 90 millivolts. Okay, the resting membrane potential is minus 90 millivolts. So what will happen, that there is going to be entry of the sodium ions and there is going to be positivity. But remember, I always in the action when we were dealing with the action potential also, at that time also I told you that once they cross the threshold, that is between minus 55 millivolts or minus 40 millivolts, unless and until they cross this threshold, okay, unless and until they cross this threshold, this is going to be a local potential. So this local potential is called as the muscle end plate potential. So once, unless and until you reach the threshold and you convert this into an action potential, you cannot complete your excitation contraction coupling, or you cannot complete the depolarization nicely. So the initial potential is going to be called as the muscle end plate potential. So if you are asked, or if you get a short note, what are the features or what are the characteristics of the muscle end plate potential, you must remember that it is generated by acetylcholine gated channels, which are present on the side of the muscle, which we called as the postsynaptic membrane, right? The magnitude of this, okay, its magnitude is going to be around minus 50 millivolts from the resting membrane potential. ठीक है, its magnitude is going to be about minus 50 millivolts from the resting membrane potential. The main ionic basis is sodium influx and a very small amount of potassium efflux and calcium influx. However, these are minor. So when I'm writing my answer or when I'm giving an MCQ, I have to remember sodium. Right now, it is a local potential, that means it is a graded potential. So it will totally depend upon the number of acetylcholine channels that are open. So if more number of the acetylcholine channels are open, more will be the magnitude of this end plate potential, and you will convert this end plate potential into what? Into an action potential. Right, so more the number of opening of the acetylcholine channels, more will be the opening or more will be the magnitude of this local end plate potential. Right, if you are anytime asked what is miniature end plate potential, so miniature end plate potential is just when there is a release of single vesicle of acetylcholine. A single vesicle of acetylcholine, just एक vesicle, मतलब 10,000 molecules, which will just bring about a change in a magnitude of 0.4 millivolts. इतना सा, that is totally insignificant. Okay, it is totally insignificant. So muscle end plate potential is a local potential, same characteristic as the graded potential. Unless and until this local potential it gets converted or it crosses the threshold for excitation, it will not be converted into an action potential. And if you do not convert this into an action potential, you cannot bring about sufficient depolarization and the further process of excitation contraction coupling. तो इतना आपको मतलब लेकर ही जाना है, and जाएगा वो, क्यों जाएगा? Because there is a safety factor. What is the safety factor? It says that every muscle end plate potential which is required to stimulate, you get about 3 times the muscle end plate potential that is needed to generate action potential. This is the safety factor. So itna muscle end plate potential develop hota hai, which is around 3 times which is needed to convert this muscle end plate potential into a full-fledged action potential. So you have got lots of safety factor at the level of NMJ, that the amount of the muscle end plate potential that is being generated is 3 times of what is needed. This is what is called as safety factor. Okay. Now we will now elaborate, or we will now write or learn in the form of a flow chart what are the events which take place at neuromuscular junction, and this is exactly the way the question is asked to you. Okay, it is exactly the way the question is asked to you. So up till now I hope everything is clear. If there's anything which is any doubt, then you can just let me know. Okay. Now, so first thing which we get is the structure of neuromuscular junction, and the second thing which we are going to get is the how do we initiate, or what are the events at neuromuscular junction. Now the first thing, let us first, text the see. Now an action potential arises at the NMJ. Okay, action potential arises at the NMJ. I'll explain you also with the help of the figure, but पहले एक बार हम लोग ऐसे देख लेते हैं. So what happens is that the action potential, it arises at the level of a So action potential arising at the end of the NMJ. So the action potential has arrived, and I told you that there are voltage gated calcium channels over here. So this is going to be the action potential which will come, and this is going to open the voltage gated calcium channel. So there is opening of the voltage gated calcium channels. Once these channels are opened, the calcium molecules will enter inside. So the first step was the action potential resulting in the opening of the voltage gated calcium channels. Once this calcium comes into the into your NMJ at the presynaptic, so you must remember that they are going to bring about activation of the calcium calmodulin dependent protein kinases to cause phosphorylation and docking. Utna nahi bhi yaad raha, so you can write down that it is going to then bring about the fusion of the vesicles and release of acetylcholine. So the second step is going to be the release of acetylcholine into the synaptic space, right? So once there is release of acetylcholine into the synaptic space, this acetylcholine, that is 2 molecules each, are going to bind on their receptor. Again, what is the receptor? It is nicotinic receptor. Where it is present on the muscle वाला side, muscle end plate वाला side, जिसको हम लोग post synaptic भी बोलते हैं, ठीक है? Which we also called as post synaptic. So what will happen once there is binding of the acetylcholine? There is going to be opening of these channels, and because it is maximally permeable to sodium, so there is going to be influx of sodium ions, right? There is going to be the influx of sodium ions. When there is maximum influx of the sodium ions, and you create what is called as the muscle end plate potential, okay? You're going to create a muscle end plate potential. When it crosses the threshold for excitation, it is going to be converted into an action potential. right? So a local potential is being generated at the neuromuscular junction, which is then going to be converted into an action potential. Now once there is summing up, मतलब एक बार जब acetylcholine अपना काम कर लेगा, तो you will have to definitely write in your answer there has to be destruction or there has to be removal of acetylcholine, because if acetylcholine is present continuously, then continuous depolarization, a persistent depolarization can occur, which is not needed and which is something which we do not want. हमको नहीं चाहिए कि persistent depolarization होना चाहिए. So if your question is on the events of neuromuscular junction, you will have to finally end up with your answer that this action potential will then travel to muscle membrane. Okay, it will then travel to muscle membrane and finally it is going to result in the muscle contraction, which we will just see in a couple of seconds later when we try to also study the excitation contraction coupling. So abhi ke liye what are the steps? So first there is release of acetylcholine into the synaptic space, that is brought about by action potential, because action potential is opening the voltage gated sodium channel, voltage gated calcium channels. So we'll just study with the help of the figure over here. हाँ, देखो, this action potential will travel. Once this action potential will travel, calcium channels which will be present will open. Calcium influx will be there, which will result in the docking and the release of the neurotransmitter substance, that is acetylcholine. Acetylcholine will then bind to its receptors. Okay, it will then bind to its receptors which are present on the mouth of the subneural cleft. Once it binds to its receptor, there is going to be the opening of the channel. As the channel opens, maximum permeability or the most important ion that is allowed is sodium. So sodium is going to enter inside. Once sodium enters inside and there is neutralization of the negativity and the inside of the membrane becomes positive, crosses the threshold of excitation and the muscle end plate potential will be converted into an action potential. This action potential will be now traveling to the muscle membrane to bring about the muscle contraction, which we will see after some time. But आपका आंसर वहां तक आना चाहिए. Plus आपको लिखना है that after acetylcholine has brought about its action, it is removed. How? Either it is removed, maximally it is removed by the enzyme acetylcholine esterase, which is going to convert it into acetate and choline is going to be used for recycling. Okay, and small amount of it will be removed by diffusion. So itna jo hai wo aapka answer aana chahiye. Short note you can also get on the muscle end plate potential, right? Now if this is clear, now we can go towards the applied part, that is myasthenia gravis. What is myasthenia gravis and all that part we will see now. Okay, then see there are different drugs which act upon the neuromuscular junction, which is again a question which has to be studied over here itself, because next year aapko ye lagega. देखो, step 1 release of calcium, right? Step 2 calcium influx. Step 2 release of the acetylcholine. Step 3 binding of the receptor, sodium influx. ठीक है, you can see sodium influx, and finally there is going to be the action that is brought about, and it is going to be removed by the by the enzyme. Now, what is myasthenia gravis basically? The first thing which you should remember regarding myasthenia gravis is that it is a disease which is an autoimmune disorder. There are autoantibodies against the nicotinic receptors. The first thing which we should come into your mind is an autoimmune disease where autoantibodies are formed. So, myasthenia gravis. Remember, it is a disease of the postsynaptic membrane. Why am I writing this? I'll clarify that why am I specifically giving you कि वो postsynaptic membrane है. So it is the disease of the postsynaptic membrane. It is not a very common disease, but still 1 in 20,000 people where there is muscle weakness. Okay, it is mainly characterized. So first statement जो आपको आना चाहिए वो आना चाहिए कि it is an autoimmune disease. ठीक है. सेकेंड स्टेटमेंट जो आपको आना चाहिए, इट इज मसल वीकनेस. Okay, there is muscle weakness because of the inability, due to the inability of neuromuscular junction to transmit enough signals, from the nerve fibers, to the muscle membrane, isn't it? You require the action potential to be transported from the nerve fiber to the muscle membrane. तब जाके आपके muscle membrane will be in the situation to release the calcium from the stores and to cause muscle contraction. So ये नहीं generate कर पा रहा है. That means the end plate potentials over here are very very weak. Okay, the end plate potentials over here are very weak. You are not getting initially or sufficient amount of sodium influx, and there are autoantibodies. Okay, there are autoantibodies. Where is the target site? The target site of this autoantibodies are nicotinic acetylcholine receptors on the muscle sites that we called as the postsynaptic membrane. Okay, so the target site is the antibodies which are present. So there are circulating antibodies which will bind with the nicotinic acetylcholine receptors. What do? They cause decline in the number of acetylcholine receptors on the motor end plate. Decline in the number of the acetylcholine receptors on the motor end plate. This they cause, and because of this there is a decrease in the size of end plate potential, right? There is a decrease in the size of the end plate potential, and because of this there is difficulty to depolarize the membrane, the muscle membrane, so as to cause a sufficient amount of action potential to complete your muscle contraction. So there is a difficulty or difficult to depolarize the muscle membrane. Right? So this complete answer, what you can do is you can just write in the form of a flow chart. The answer becomes very beautiful also, and it gives a better understanding to the teacher also कि आप लोगों को आता है when the teacher is correcting your paper, when the examiner is correcting the paper. Now I'll just help you out in knowing the clinical symptoms also. So myasthenia gravis is a disease which mainly causes the weakness of the muscles. So there is weakness of the muscles of the eyelids. Weakness of the muscles of eyelids, which is your levator palpebrae. And because there is a weakness in the muscle of the eyelids, that is the levator palpebrae, what symptom you get is ptosis. And what is ptosis? It is drooping of the eyelid. Okay, it is drooping of the eyelid. Okay, first thing, there is weakness of muscles of the eyelids. Second is there is weakness of the extraocular muscles. Extraocular muscles are also weakened. So because there is weakness of the extraocular muscles, what is called is diplopia. Diplopia का मतलब क्या होता है? Double vision. Okay, diplopia का मतलब होता है double vision. Then third important thing is there is, see, it is a disease of the muscles, so there is even difficulty in chewing the food, and therefore easy fatigability during mastication. So this is the physiological basis of the symptoms of the disease. ऐसे आपको क्वेश्चन पूछते हैं ना, what is the physiological basis of the symptoms of the disease, what is the physiological basis of the treatment of the disease. ठीक है? So there is ability or there is weakness affecting the ability to chew and swallow, affecting the ability to chew and swallow. So because of this there is easy fatigability during mastication, or the person gets tired with mastication. Then weakness also in the muscles responsible for speech. This is also very important, you know, that there is weakness in speech also. Okay, there is weakness in speech also. And very important, there can be sometimes respiratory muscle paralysis, which could be the cause of death in these patients, right? There can be respiratory muscle paralysis, some of the important complication or this which can occur over here. Now, what is the physiological basis of treatment over this? Okay, what is the physiological basis of treatment? And then we will try to find out this answer also, that what is the difference in the bronchial junction. Now see. Now in myasthenia gravis, as I told you, antibodies are formed. They are circulating, binding to the nicotinic receptors. So when the antibodies are bound to the receptors are not available to be activated by acetylcholine, right? And there are no sufficient action potentials or depolarization. Now we give drug of choice as acetylcholine esterase inhibitors. You know that the enzyme acetylcholine esterase brings about the hydrolysis or the breakdown of acetylcholine and helps in termination of the action. तो हम क्या देंगे, हम ऐसे drugs देंगे which are inhibitors of this enzyme. So we are giving acetylcholine esterase inhibitors like pyridostigmine, that is going to bind to the acetylcholine esterase, so that the binding and the degradation of acetylcholine at the muscle end plate can be inhibited. Okay, so that the binding and the degradation of the acetylcholine at the muscle end plate can be inhibited. So because the available acetylcholine is not degraded, ठीक है, मतलब जितना acetylcholine release हुआ, it is not degraded, what will happen? The availability of the acetylcholine will increase. And if the availability of the acetylcholine is increased, then the muscle end plate is exposed to higher concentrations of acetylcholine that will increase the magnitude or size of the graded potential, and that will increase the likelihood of the action potentials, right? You will increase the magnitude or the size of the end plate potentials, and you will increase the number of action potentials which are produced. So this is the physiological basis of the symptoms and the treatment of myasthenia gravis. Now the other disease which you get over here is Lambert-Eaton syndrome. Lambert-Eaton syndrome. So Lambert-Eaton syndrome में क्या होता है? यहाँ पर there are autoantibodies on the voltage gated calcium channels. इसका मतलब क्या हुआ? Lambert-Eaton syndrome is present presynaptically, isn't it? It is present presynaptically. और जो आपका ये था वो पोस्टसिनेप्टिकली था. माइस्थीनिया ग्रेविस कहाँ था? पोस्टसिनेप्टिकली. तो इसमें कैसे हो जाता है? बिकॉज देयर आर ऑटो एंटीबॉडीज अगेंस्ट द वोल्टेज गेटेड कैल्शियम चैनल्स, देयर इज अ डिक्रीज इन द कैल्शियम इनफ्लक्स. ओके, देयर इज अ डिक्रीज इन द कैल्शियम इनफ्लक्स. अब अगर कैल्शियम इनफ्लक्स ही आपने कम कर दिया तो आगे की स्टोरी तो खत्म हो गई. दैट मीन्स less number of synaptic vesicles will be released, will be dogged. So ultimately you are decreasing less, or you are decreasing the amount of availability of acetylcholine, है ना? क्योंकि आपको कैल्शियम चाहिए सो दैट आप डॉकिंग करवा पाओ, एक्सोसाइटोसिस करवा पाओ. अब आपके पास कैल्शियम ही नहीं रहेगा तो क्या होने वाला है? There is going to be less amount of release of availability of acetylcholine. But remember, यहाँ पर ना एक बहुत इंपॉर्टेंट सिम्टम जो आपको मिलेगा इन कंपैरिजन टू द माइस्थीनिया ग्रेविस विच इज मेनली इन्वॉल्विंग द फेशियल मसल्स, यहाँ पर मेनली द लोअर लिम्ब मसल्स आर इन्वॉल्व्ड. ओके, लोअर लिम्स आर मोर इन्वॉल्व्ड इन कंपैरिजन टू प्रॉक्सिमल लिम्स, लोअर लिम्स. एंड क्लिनिकली दिस फीचर लाइक माइस्थीनिया में कैसे होता है? विद एक्सरसाइज द पर्सन गेट्स फटीग्ड. ठीक है, विद एक्सरसाइज द पर्सन गेट्स फटीग्ड. बट यहां पर विद एक्सरसाइज देयर इज इंप्रूवमेंट. with exercise there is improvement, because every time the person is going to exercise or there is going to be electrical stimulation, every time small amount of calcium is going to be released. That calcium will bring about the release of acetylcholine, and acetylcholine will now try to complete the action potential. और अगर आप माइस्थीनिया ग्रेविस में रिपीटेड स्टिमुलेशन करेंगे तो वो पेशेंट का फटीग बढ़ जाएगा. ओके, पेशेंट का फटीग बढ़ जाएगा. सो क्लिनिकल हिस्ट्री में the patient of the myasthenia gravis will give you a history that I feel proper, the patient feels comfortable after rest, but Lambert-Eaton में the patient is comfortable or feels a bit of energy after he does some kind of work. So exercise deteriorates myasthenia gravis, but exercise improves Lambert-Eaton syndrome. This is a very classical feature. Myasthenia mainly involving the upper limbs, but Lambert-Eaton mainly involving the lower limbs. Waddling gait is a common feature, and sometimes it is also known to be, present with small cell carcinoma of lung. Small cell carcinoma of lung. It is very commonly associated when the patient has got a small cell carcinoma of lung. साथ में you're going to get this. ठीक है. Now, I hope up till now there is no problem with there is, because I'm not getting any comment from your side or any difficulty. Yes. Good evening, Mudit. Yes. Myasthenia gravis में end plate potential कम हो जाता है. Yes. In myasthenia gravis, the size or the amplitude of the muscle end plate potential will decrease. ठीक है, the size or the amplitude of the muscle end plate potential will decrease. क्यों डिक्रीज हो जाएगा? बिकॉज muscle end plate potential is a local potential. It depends upon the amount of acetylcholine that is available. तो अगर acetylcholine कम हो गया, ठीक है, अगर acetylcholine की availability कम हो गई तो जो साइज है हमारा एक्शन पोटेंशियल का, मसल एक्शन पोटेंशियल का, वो भी कम हो जाएगा. राइट. फिर इसके बाद एक और चीज हमको जो यहाँ पर समझनी चाहिए वो होती है बोटुलिनम टॉक्सिन. Now, botulinum toxin is present in the bacteria, that is the Clostridium botulinum bacteria. Now, this botulinum toxin can also cause flaccid paralysis. Okay, it can cause flaccid paralysis because it interferes with the action of the docking proteins. Okay, it interferes with the action of the docking proteins, and therefore it interferes with the release of acetylcholine. It interferes with the action of docking proteins, therefore it interferes with the release of acetylcholine. Acetylcholine release नहीं हो पाता है, and that is the reason where there is flaccid paralysis with botulinum toxin. Remember, this is the same Botox which is used in conditions like achalasia cardia. It is a kind of a relaxant to the muscle. Okay, achalasia cardia. It is the thing which is also done to decrease the facial wrinkles. You might have studied or you might have read cosmetically it is being reduced as anti-aging. It is a kind of a muscle relaxant which is used to decrease the facial wrinkles, or the Botox treatment cosmetically, and anti-aging treatment which is done and also used in conditions like achalasia cardia. Right. Now we come to another important thing is that is certain drugs which are acting on the neuromuscular junction. तो ये भी आपको मतलब सेकेंड ईयर में तो ये आपको बहुत ज्यादा इंपॉर्टेंट हो जाता है. That you should also know certain drugs which are acting on the muscle on this. So first we've just studied, it was the botulinum toxin which interferes with the docking proteins and blocks the release of acetylcholine. Then there is Curare. Curare is the same toxin, Curare is the same toxin which I told you is also applied on the arrows for hunting. It basically competes with acetylcholine, right? It competes with the acetylcholine receptors which are present on the motor end plate, and therefore it decreases the size of the end plate potential. Decreases the size of the end plate potential, and if the dose of this Curare is more, it can cause respiratory paralysis and death. So snake poisons जो होते हैं, especially cobra bite, ठीक है, cobra bite जो होता है, cobra bite में there is a Curare like neurotoxin. Okay, you must remember that cobra bite, the person can die with cobra because it has got a Curare like neurotoxin. Curare like neurotoxin which causes these symptoms. Then you have got neostigmin, physostigmin, which are anticholinesterases, which inhibits the action of acetylcholinesterase and therefore brings availability of acetylcholine. That means it prevents the breakdown of acetylcholine. Therefore, the amount for which the acetylcholine available is more. Then there are certain drugs like hemicholinum, which blocks the reuptake of choline. And if you block the reuptake of choline, you know that choline is very important. उसी को आपको recycle करके फिर से बनाना है acetylcholine. इसीलिए if you block the reuptake of choline into the presynaptic terminal, you are going to deplete the acetylcholine का storage. Okay, you're going to deplete the acetylcholine का storage from the presynaptic terminal. Right? So this is the drugs acting: Sullivan-Deaton syndrome, myasthenia gravis, botulinum toxin, and certain drugs which are important. Then another thing which you should know is organophosphorus poisoning or the OP poisoning, because they are also very common cases which you are going to get in your wards next year. जब आप wards में जाएंगे तो आपको OP poisoning के बहुत सारे cases मिलेंगे. Organophosphorus poisoning, it is commonly called as the OP poisoning. Remember, these are basically anticholinesterases. Okay, they are anticholinesterases and these are used in agriculture because these are a part of the insecticides. So OP poisoning के cases are very common, suicidal as well as homicidal cases. गाँव से जो आते हैं, they very commonly come with this OP poisoning का cases, and homicidal and suicidal cases are very common because they are added up in the insecticides. So once this organophosphorus poisoning is there and there is anticholinesterase, that means you are prolonging the action of acetylcholine. And now when you are increasing the availability of acetylcholine, it is not only going to be available in the neuromuscular junction, but there are going to be variety of symptoms, right? Because it is going to activate the muscarinic and it is going to activate the nicotinic receptors. So you can get a variety of symptoms like lacrimation, salivation, involuntary defecation and urination. Involuntary defecation, urination. There can be vascular collapse because there is a decrease in the blood pressure, decrease in heart rate. The muscle fasciculation or fasciculation के बाद में there can be even muscle paralysis. There can be central symptoms like irritability, drowsiness, and the death of this person can be because of respiratory failure. Okay, the death of the person can be because of respiratory failure. So you give drugs like atropine, which is antidote. Okay, drugs like atropine, which is antidote to be given with OP poisoning, right? So I think this much knowing about the topic is sufficient to you. Case history is not common on Sullivan-Deaton syndrome for UGs, but it is more common as a PG MCQ question. Okay, but आपको आना चाहिए, लेकिन UGs के लिए myasthenia gravis is very important. Now we come to what is called as the excitation contraction coupling. How are you correlating this with the muscle contraction? So what is taking place is the events which are taking place at the neuromuscular junction is going to result in the contraction, right? They're going to result in the contraction, what we called as excitation contraction coupling. Excitation contraction coupling. Okay, so this comes as LAQ. और जब ये LAQ जैसे आता है तो I have seen that the students are not able to write. They don't understand what is to be written when the question is asked on excitation contraction coupling. So what is the definition? The definition is the process by which action potential. So what is action potential? It is excitation. Okay, what is action potential? It is excitation. The process by which action potential, that is excitation, on the surface of the cell membrane cell membrane triggers the contraction of the muscles. Triggers the contraction of the muscle with the help of calcium ions, and contraction of the muscle is going to be a mechanical event. So when there is coupling of these two events, electrical event, that is excitation on the surface of the cell membrane, which we called as action potential, it triggers the contraction of the muscle, which is the mechanical event. And who is the coupling agent? The coupling agent is calcium. Okay, the coupling agent is calcium. Now we will be in the next lecture we will be in detail studying the structure of the skeletal muscles. But यहाँ पर हमको आंसर कैसे लिखना है, what should be the part of our answer should be known to us. Now when we will study muscle, we will see that the muscle is elongated muscle fiber, and this muscle membrane is called as sarcolemma. It is called as sarcolemma. Now there is great thickness of the muscle, and you want that the muscle should contract, right? For the muscle to contract, the action potentials or the depolarization should spread to the entire depth of the muscle, है ना? The action potential है, क्यों आपको चाहिए? क्योंकि वहां पर से आपको कैल्शियम रिलीज करवाना है. You have to release calcium. So when you have to bring about the release of calcium, you want that those membrane potentials should reach the depth, and then only the calcium will be released, and then only there will be muscle contraction. So आपने क्या किया है, जो आपका मसल मेम्ब्रेन है सार्कोलेमा, उसको आपने डिप कर दिया, ऐसे टी बना दिया है. So you have dipped the sarcolemma like this. This dip which is forming a T is called as transverse tubule. Okay, the dip which is forming the T is called as transverse tubule, and you can see that this tip, the mouth of the tip is outside one, okay, and it is filled with ECF, whereas the other part is going towards the other end of the muscle. That means trying to reach the depth of the muscle, okay, trying to reach the depth of the muscle, right? So there is dipping of the sarcolemma inside. At one end, which is open, will be filled with ECF, and on the other end there is going to be, it is going to, at the other end is the muscle wala side, right? So ab jab action potential aayega from NMJ, this action potential will not travel like this straight. ऐसा straight travel नहीं करेगा. What will happen? The action potential will dip like this. It will dip because you have created these T tubules or the dips, and therefore it is now going to dip into the interior, because there is some reason that why we want the dipping. So what is the function of T tubule? The function of the T tubule is to transmit the action potentials into the interior of the muscle, into the interior of the muscle. Okay, so the function of the action potential, the function of the T tubule or the transverse tubule is to dip the interior action potentials into the interior of the muscle. Now the skeletal muscle has got a very, very extensive endoplasmic reticulum, which we called as the sarcoplasmic reticulum. Now this sarcoplasmic reticulum has got large chambers. See, you can see over here, terminal cisternae. This terminal cisterns which abut into the T tubules. Okay, it has got terminal cisterns that abut into the T tubules, and there are longitudinal tubules. Can you see the longitudinal tubules which are all surrounding the myofibrils? So these longitudinal tubules or the L tubules are actually the storehouse of calcium. Storehouse of calcium. So you have got T tubules, which are the extensions of the sarcolemma. You have got sarcoplasmic reticulum, which has got these dilated parts or the chambers which are called as terminal cisterns, which abut into the T tubules, and you have got longitudinal or the L tubules, and I told you that these L tubules are the storehouse of calcium. So you can excuse me, you can see that this is the L tubule, T tubule, L tubule. This forms a triad. This forms a triad, and there are about 2 triads per sarcomere. There are about 2 triads per sarcomere in the skeletal muscle, right? 2 triads per sarcomere in the skeletal muscle, and just beneath the triad, yahan par, in the skeletal muscle, you will see the actin myosin overlapping like this, the overlapping of the AI bands. Okay, so we will see later on what are the AI bands. So there are 2 sarcomeres, there are 2 triads per sarcomere, there are 2 triads per sarcomere, and just beneath the triad, what you are getting is the AI bands. Also in the skeletal muscles, the T-tubules are long and narrow. Okay? In the skeletal muscles, the T-tubules, they are long and narrow. Right? But if you see in the cardiac muscle, you will see that the T-tubules are like this. They are short and wide. And you don't have a triad, but you have a dyad. So in the cardiac muscles, instead of a triad, you have got a dyad, and the T-tubules, they are short and wide. What is the reason? The reason is that they are containing excessive ECF and calcium ions. बहुत सारा calcium ion होता है, right? क्यों होता है? Because in the case of skeletal muscle, when the muscle wants to contract, okay, when the skeletal muscle wants to contract, the entire calcium is coming from the L-tubules. That means from the sarcoplasmic reticulum. The skeletal muscles have got a very large storehouse of calcium. They do not need any extra calcium. उनको बाहर का calcium की ज़रूरत नहीं है. So the entire calcium is coming from the from the sarcoplasmic reticulum, that is from the L-tubules, and therefore the T-tubules are long and narrow. But in the case of cardiac muscles, the storehouse of calcium is the L-tubules, but 2/3 of the calcium in the case of the cardiac muscle is coming from the ECF. Therefore the T-tubules are short and wide. Okay, therefore they are short and wide, so that they contain lots of ECF, and lots of ECF means they contain lots of calcium ions, and 1/3 of the calcium is coming from the L-tubules. So cardiac muscles में जितना आपको calcium चाहिए muscle contraction के लिए, 2/3 of the calcium is coming from the ECF, and 1/3 of the calcium is coming from the sarcoplasmic reticulum. Right? But in the case of skeletal muscle, the entire calcium that is required to cause muscle contraction is coming from the L-tubules, from the sarcoplasmic reticulum. They are not at all depending upon the ECF calcium. This has to be remembered, right? Now let us look into the structure in more detail. So we've studied the definition of excitation contraction coupling, the structure of the L-tubules and T-tubules, and their differences in the skeletal muscle and the cardiac muscle. दोनों में क्या differences है? Right? Now this T-tubules, okay, these T-tubules, they have got DHP receptors. Okay, they have got DHP receptors, which is called as dihydropyridine receptors. Dihydropyridine receptors. These dihydropyridine receptors are linked to another channels which are present on the L-tubules, and on the L-tubules here you have got which is called as the ryanodine receptors. Okay, ryanodine receptors. So it is this is achieved because the dihydropyridine receptors are physically connected. Okay, they are physically connected to the ryanodine receptors through a junctional proteins which is called as junctophyllin or junctophyllin. Junctophyllin. So junctophyllin is a protein complex. Junctophyllin bolo ya junctophyllin. ठीक है, junction से junctophyllin. It is a protein complex that is bringing about the interaction between the dihydropyridine and the ryanodine receptors. How they are related we will see. कि उनका यूज क्या है, how they are related. Now there is going to be a calcium pump. What is the role of this calcium pump? It is called as Serca pump. It is a calcium ATPase pump. Remember, example of a primary transport mechanism. Like जैसे सोडियम पोटेशियम वैसे प्राइमरी ट्रांसपोर्ट मैकेनिज्म. This is sarcoplasmic endoplasmic reticulum. Sarcoplasmic endoplasmic reticulum. Calcium ATPase pump बोलते हैं. This wall or this pump is present in the walls of sarcoplasmic reticulum. So when the muscle contraction is over, right? When the muscle contraction is over, that means once the calcium have been released and the calcium concentration remains high, which is needed for the muscle contraction, this calcium pump will concentrate the calcium ions back into the sarcoplasmic reticulum, back into the sarcoplasmic reticulum, and it can increase about 10,000 fold concentration inside the tubules. ठीक है, मतलब मसल कॉन्ट्रैक्शन के लिए आपको कैल्शियम चाहिए. सो दिस कैल्शियम विल बी रिलीज्ड इनटू द साइटोसोल ऑफ द मसल. Once the muscle contraction is done, this calcium pump, which we called as the Serca pump, will ensure that the calcium is coming back into the sarcoplasmic reticulum. And about 10,000 fold increase it can bring about the concentration. And another, remember that also there is a protein in the sarcoplasmic reticulum which is called as chaliquestrin. Chaliquestrin that can bind to calcium. So this is the calcium binding protein which is present, which can bind to the calcium. Now, what is calcium pulse? Okay, what do you call as calcium pulse? So in the resting state, that means when the muscle is not contracting, the calcium concentration in the cytosol is less than 10 to the power minus 7 moles per liter. राइट मसल का जो साइटोप्लाज्म है, मसल का जो साइटोप्लाज्म है, उसमें रेस्टिंग कंडीशन में मसल कितना कैल्शियम होता है? बहुत कम होता है, 10 to the power minus 7, because you do not want the interaction of actin and myosin. You don't want the muscle to get contracted. So why do you want calcium, isn't it? But when and remember, at this calcium concentration, which is just 10 to the power minus 7, the active sites on actin, will be covered, or they will be under inhibition of the troponin tropomyosin complex. They will be under the inhibition of the troponin tropomyosin complex. Okay, they will be under the inhibition of the troponin tropomyosin complex. Now don't get confused what is troponin tropomyosin complex. You will be learning them all in the next class when we study the molecular structure of muscle contraction. But now just remember कि resting state में हमको muscle का contraction नहीं चाहिए, तो हम क्या करेंगे? जो active sites है उसको cover कर देंगे troponin tropomyosin complex से. और जब calcium concentration कम होता है, then the active sites are already under the inhibitory control of troponin and tropomyosin. But when there is full excitation of the T tubules, right? When there is full excitation of the T tubules by the action potential, calcium will be released. Then the calcium concentration in the cytosol will become 2 into 10 to the power minus 4. That means around 500 times more concentration. ठीक है, तो पहले कितना था? 10 into 10 to the power 10 to the power minus 7. But when there is full excitation and when you want to release the calcium for muscle contraction, the concentration is 500 times more. 2 into 10 to the power minus 4 moles per liter. This is what is called as calcium pulse. ठीक है, calcium pulse. So with each action potential, this much amount of calcium is released, which is called as calcium pulse. And the duration of this calcium pulse in the skeletal muscle is only 1/20th of a second. Right? The duration of this calcium pulse in the case of skeletal muscle is only 1/20th of a second, but in the case of cardiac muscle it is 1/3 of a second. Okay, it is 1/3 of a second. So that is the difference in the skeletal muscle and cardiac muscle. So whenever we are studying, it is very important that not only to remember the similarities but to remember the differences in the types of muscles. Okay, so the difference in the sarcotubular system, in the skeletal muscle, cardiac muscle, and the duration of the calcium pulse, दोनों को आपको ध्यान रखना है. Right? Now let us understand what is the excitation contraction coupling and how it will occur. First we'll just look into the figure and then we'll try to understand everything in the form of a flow chart. Now see, what will happen? There will be the action potential. This action potential is the same action potential which we generated at the level of NMJ, right? The same action potential which we generated at the level of NMJ. Now this action potential will travel, and it will dip inside the T tubules, because you already have created the dips, because you want the action potential to travel down. So it will go into the tip and it will open the voltage gated DHP receptors. Okay, so this action potential will open the voltage gated DHP receptors. Remember, they are voltage gated. Okay, they are voltage gated. Once this are opened, they bring about a lock and key configuration. Okay, they bring about a lock and key configuration, and they open the ryanodine receptors or the ryanodine channels. Once the ryanodine channels are open, what will happen? There is going to be the release of calcium ions into the muscle cytosol. Okay, there is going to be the release of calcium ions into the muscle cytosol. These calcium ions are now going to bind to your troponin C. Okay, once the calcium ions bind to troponin C, there is again going to be interactive forces which will cause the troponin tropomyosin complex, which will cause the troponin tropomyosin complex to get shifted. Okay, shifted in the way that they expose the active sites of actin. They expose the active sites of actin, right? And once the active sites of actin are exposed, there is going to be the interaction. There is going to be the interaction between the cross bridges of myosin, interaction between the cross bridges of myosin with the active sites of actin, which is going to result in your muscle contraction. Okay, that is going to result in the muscle contraction. So how did we start? Action potential at the neuromuscular junction, traveling along the T tubules, opening the voltage gated DHP receptors. DHP receptors mechanically or physically connected to the ryanodine channels, opening of the ryanodine channels, release of calcium, calcium binding to troponin C. Okay, calcium binding to troponin C. This laterally or shifts the troponin tropomyosin complex, which exposes the active sites of actin, which is now going to interact with the cross bridges of your myosin, and there is going to be the cross bridge activity or the muscle contraction. So this we called as the excitation contraction coupling. Now another difference I'll tell you over here is between the cardiac muscle and the skeletal muscle. We will repeat this when we study cardiac muscle also. So first we saw that in the skeletal muscle there is a triad, but in the cardiac muscle there is a dyad. In the skeletal muscle we saw that the T tubules were long and narrow, but in the cardiac muscles they are short and wide. In the skeletal muscles, the source of contraction, the source of calcium for the muscle contraction is totally sarcoplasmic reticulum. They are not dependent upon ECF calcium. लेकिन cardiac muscles में 2/3 of the calcium is coming from the ECF and only 1/3 of the calcium is coming from the sarcoplasmic reticulum. Then the calcium pulse in the skeletal muscles is how much? The calcium pulse is 1/20th of a second. Okay, 1/20th of a second is the calcium pulse. लेकिन cardiac muscle में it is 1/3. That means longer. Now, in the skeletal muscles, the DHP receptors are only acting as voltage sensors. Voltage sensors. And they just have got a mechanical interaction with the ryanodine receptors. सो जस्ट जैसे ताला खोलेगा, ओके, जैसे एक लॉक है तो लॉक को की खोलेगा, isn't it? You have got a key which will open the lock. वैसे उनका कॉन्फ़िगरेशन है. लेकिन in the case of your cardiac muscles, this DHP receptors are going to release calcium. Okay, the DHP receptors are going to release calcium, and this calcium will then open, okay, this calcium will then open the ryanodine receptors. So this is called as calcium induced calcium release. It is called as calcium induced calcium release. So these are the differences between the skeletal muscle and the cardiac muscle. If you remember this, you will be also able to cover many of the MCQs which are expected from this, and even the Viva questions can be covered by this much. Right? Now the next part which you should understand is that there is if there is a mutation in the ryanodine receptor, okay, if there is a mutation in the ryanodine receptor, which is also called as a channelopathy, it is called as a channelopathy, and the mutation of this causes continuous release of calcium. So because of the continuous release of calcium or the continuous availability of calcium, this is going to result in excessive muscle contraction. It is going to result in excessive muscle contraction, और उसके वजह से you will see that there is increase in the temperature of the muscle also. So excessive muscle contraction with increase in the temperature of the muscle, and this condition is clinically called as malignant hyperthermia. Malignant hyperthermia. So what is malignant hyperthermia? It is a condition where there is a mutation of the ryanodine receptors, and with the mutation of the ryanodine receptors there is a continuous release of calcium causing persistent muscle contraction, clinically reflected as increase in the temperature also of the muscle, and that is called as malignant hyperthermia. ठीक है, चलो. Now what I'll do is I'll just give you a mnemonic. So just remember can, arm. Can, arm. What is can? Calcium entry, release of acetylcholine. Calcium entry, release of acetylcholine. Acetylcholine binding to the nicotinic receptors. Acetylcholine binding to the nicotinic receptors. That is causing an action potential. Why? Because nicotinic receptors will open and they will cause the sodium influx. Okay, sodium influx. Action potential, and then this action potential will travel along the T tubules, which will ultimately release calcium from the stores. And this is going to result in your muscle contraction. It is eventually going to result in your muscle contraction. Okay, so you can remember the entire this with the help of this can, arm. So calcium entry, acetylcholine release, nicotinic receptors binding, sodium influx उसके वजह से, action potential traveling to the T tubules, releasing calcium from the calcium stores, and ultimately muscle contraction. So excitation contraction coupling means you are coupling the electrical events, that is the action potential at the NMJ, with the muscle contraction, which is a mechanical event, and the coupling agent is called as calcium. Right? So these two are very, very favorite questions which come in the exam. बहुत ज़्यादा आते हैं ये. Excitation contraction coupling and your this thing. Right? Molecular events of calcium muscle contraction we will see in the next lecture. Now before I take you, we'll just look into the types of the muscles. See, you have got three muscles: skeletal muscle, smooth muscle and cardiac muscles. ठीक है, ये तीन muscles है आपके पास, जिसमें से आपका skeletal muscle is striated, cardiac muscle is striated, but smooth muscle में there are no striations, right? Skeletal muscle is the only voluntary muscle because obviously cardiac muscle is going to be involuntary and smooth muscle is also going to be involuntary, right? In the case of skeletal muscles, the upstroke of the action potential is because of sodium influx. So when we speak of the upstroke, that means when we speak of depolarization, it is because of the sodium influx in skeletal muscles. In the cardiac muscles, in the ventricles, atria and Purkinje fibers, यहाँ पर you get a plateau potential. यहाँ पर जो depolarization है, it is because of sodium. But in the case of the SA node, the depolarization or the upward stroke is because of calcium. ठीक है, it is because of calcium. You will not see a plateau in the skeletal muscle. Rarely you can get a plateau in the स्मूथ मसल्स. छोटा सा प्लेटो आपको सस्टेन्ड कॉन्ट्रैक्शन जैसे ब्लैडर में, यूट्रस में मिल सकता है. बट इन द केस ऑफ कार्डियक मसल, the atria, the ventricles, the Purkinje fibers, they show a plateau. In the SA node, there is no plateau. Okay, in the SA node, there is no plateau. The duration of action potential you will see in the skeletal muscle 1 to 2 milliseconds. Maximum it can be 1 to 5 milliseconds also. Smooth muscle में 5 to 10 milliseconds. लेकिन cardiac muscle का जो action potential होता है, it is of a very longer duration. It is 150 milliseconds in the SA node and atria, but it can be up to 250 to 300 milliseconds. ठीक है, 250 to 300 milliseconds in the ventricles. And the longer duration of this is responsible for the longer duration of the action potential means the absolute refractory period is also more in the cardiac muscle. Then the excitation contraction coupling in the skeletal muscles, you see that there is T tubules, there is mechanical bounding or the junctioprotein bounding of the DHP receptors with the ryanodine receptors. In the case of cardiac muscles also, there is inward calcium, and this calcium mainly enters in the plateau phase of action potential. Okay, जो हमारे cardiac muscles में ऐसा plateau phase आएगा, ये plateau phase, this plateau phase is caused by calcium input, and the amount of calcium coming in the plateau phase will further increase the duration of action potential. If more calcium is coming from outside, more calcium will be released from inside. In the case of your smooth muscles, action potential opens the voltage gated. You know, there are not only voltage gated calcium channels in the smooth muscles, but the calcium channels can also be opened by neurotransmitters, by hormones, or through second messengers, right? And in the skeletal muscles, the calcium is released by the sarcoplasmic reticulum because the T tubules are only behaving as voltage sensors. But in the case of cardiac muscles, I told you that the T tubules, they release calcium. That calcium is causing increased release of calcium from the ryanodine receptors, and this is called as calcium induced calcium release. Now in skeletal muscles and cardiac muscles, the calcium is bounded to the calcium protein, that is troponin C. Okay, troponin C. So it is called as actin linked muscle contraction. Actin linked muscle contraction, because troponin C is a part of actin. और आपको कार्डियक मसल्स में भी ऐसे ही मिलेगा, एक्टिन लिंक्ड मसल कॉन्ट्रैक्शन, बिकॉज यहाँ पर भी द कैल्शियम इज गोइंग टू बाइंड टू ट्रोपोनिन सी. लेकिन आप स्मूथ मसल्स में देखेंगे दैट द कैल्शियम बाइंडिंग प्रोटीन इज कैलमोड्यूलिन. यहाँ पर दिस कैल्शियम इज बाइंडिंग टू मायोसिन लाइट चेन काइनेज, सो इट इज अ मायोसिन लिंक्ड मसल कॉन्ट्रैक्शन, right? It is a myosin linked muscle contraction. So actin linked muscle contraction and a myosin linked muscle contraction. This is very interesting, and if you are able to learn the differences between the three, you will see that again you will be able to solve many MCQs. So instead of just always remembering the similarities, it is very good to remember the differences. Okay, so what we all studied together today was the structure of the neuromuscular junction. ठीक है, then the events which take place at neuromuscular junction, the diseases which are affecting the neuromuscular junction, and what is excitation contraction coupling, because excitation contraction coupling पर भी आपको question आता है, right? Now with this we end today's lecture, and in the next lecture what we will cover will be the molecular mechanism of muscle contraction. So we will see the structure of the sarcomere, actin, myosin, what is the cross-linked cross-bridge theory or the sliding filament theory which is responsible for muscle contraction, that we will cover. If time permits, the properties of skeletal muscles and so on, right? So thank you for your patient learning, patient listening, and always be a happy learning. Thank you.